It's a pleasure to be here with you today to share my experience also with my favorite lens, the Acrysof IQ Vivity. These are my disclosures. So when surgeons are asked what's the limiting factor for them to adopt presbyopia-correcting lenses in their practice, the number one answer is visual disturbances compared to a monofocal lens. And that requires extra chair time preoperatively because you have to select the right candidate not to have those disturbances. And unfortunately, oftentimes postoperatively, pain and time when the patients are unhappy. So what should the ideal lens be able to offer? Well, the ideal lens should be a lens that delivers an extended range of vision without the visual disturbances that have been associated with diffractive IOLs. And I will show you that the Acrysof IQ Vivity lens does that, as it provides excellent distance, intermediate, and functional near vision, a visual disturbance profile comparable to the monofocal IQ lens using a new technology called wavefront shaping. When I started implanting this lens in Greece about 2.5 years ago, I was very reassured because there were already 2 large double-blind randomized controlled trials with greater than 250 patients that had been implanted this lens binocularly and were compared to a monofocal binocular implantation of the Acrysof IQ. One was the US study that gave FDA approval to the lens, and the other one was a global study with a good follow-up of 6 months. And I urge you, when you decide to go with a new lens in your practice, always look at the evidence. Oftentimes, you get a brochure of a lens and it has a defocus curve, and that's from a bench data, or oftentimes that defocus curve comes from 12 patients. And personally, I don't feel comfortable implanting a new lens, trying out a new lens in my patients that has not been tried out in a robust way. So here are the results. So in that study, in those 2 studies, the Vivity lens gave 20/20 binocular mean uncorrected distance vision, greater than 20/25 intermediate, and 20/32 for near. And when you look at the visual disturbance profile, it was really the same between the monofocal lens and the Vivity lens in terms of starburst, halos, and glare. And if you look at the bench data of how the halo profile of this lens is, it's very similar to the IQ monofocal and very different from diffractive lenses. Also, if you look at the light energy distribution, the monofocal is on the top, the Vivity is at the bottom, and there's 2 diffractive lenses in between. And you can see that the Vivity does not have the distinct focal points that we know that diffractive IOLs have, but it rather has a continuous extended focal range. And it does that through 2 transition elements, a slightly elevated smooth plateau and a small curvature change. And what these elements do is that they stretch the wavefront so that it provides this continued extended focal range, and they also shift the wavefront in front of the retina so that all of the light energy can be used, especially for good distance vision. Now today I want to share with you some real-world data. So those were the studies. It's great to see the studies. The lens got approval, meeting the ANSI standards, which are strict standards in the United States to be named that are used to be named so that the lens is named an EDOF lens. And this is real-world data. June 2020 to December 2022, 41 sites from Europe, Australia, and New Zealand, with a total number of patients of 910. So let's see how this lens performs in real practice. And in this cohort, as you can see, there are patients with comorbidities that got this lens. Patients with glaucoma, dry eye, after corneal refractive surgery, some maculopathy. There was a big number of toric lenses and Vivity that was implanted with a target of mini monovision between the 2 eyes. So if we look at the result of the overall cohort, the 910 eyes, you can see that the uncorrected distance visual acuity, the mean was 20/20, the intermediate close to 20/25, and the near 20/32. So very similar to what we saw in the trials. And this is great, that's very reassuring. In terms of spectacle independence, and the answer to the question, how often do you need to wear eyeglasses to see, most patients, as you can see, the dark blue is never and the lighter blue is rarely, said that they don't need glasses for distance and intermediate vision, both in bright and in dim light conditions. and in terms of patient satisfaction, doing several activities, such as reading the newspaper, recognizing faces, seeing the prices of goods, walking on uneven surfaces, doing handicrafts, reading TV subtitles, and engaging in an activity or a hobby. More than 90% of the patients said that they were really satisfied with their eyesight. And finally, visual disturbances, again, same results as we saw in the control trials. More than 90% of the patients reported no halos, glare, or starburst. And now I would like to show you two cases of my patients, that one had glaucoma and the other one dry eye, and how they did after implanting this lens. So before that, the glaucoma cohort in this study had 35 patients, and the results were really, really good. Again, great distance, intermediate, and functional near vision, very good spectacle independence, both in bright and dim light conditions. 85% of the patients were satisfied with their sight, and more than 90% of the patients did not have any visual disturbances. So here's my patient. I was actually 2 years ago, almost a half years ago, that I implanted this lens. So he's from Denmark. He's a retired banker. He retired in Greece. He has been a low hyperop all his life, except for the last year, where he developed a myopic cataract, and that gave him significant anisometropia. As you will see in his refraction, he's minus 1.5 in the right eye with a cataract, and plus 225 in the left eye. He is using progressive spectacles for intermediate and near, and of course, because of his anisometropia, it took a long time to get used to them. He never takes the glasses off to use the near vision that the cataract has given him. And he has glaucoma that has been stable for years. And I say stable because the reason for his glaucoma was plateau iris syndrome. And he was misdiagnosed for many years, but once this was diagnosed and he was treated with iridoplasty, his visual fields have been stable for greater than 5 years, and his pressures have been well controlled. He uses mostly his phone and his tablet, and he's motivated to get rid of his glasses, but would tolerate a small prescription for small print. All my VVT patients, I discuss with them that they will need glasses for near, and sometimes one-third of them don't end up needing glasses for near, but I never promise. The lens doesn't promise that. It promises good intermediate distance. You have to discuss they may need a small prescription, but you'll be surprised to find out that some of them will not. So in terms of his ocular surface, he did have some mild dry eye, as most people have after a certain age. And here his fundus photos. He does have glaucoma. You can see glaucomatous optic nerve on the right. This is his RNFL on the right, normal on the left. And here his visual fields, which had been exactly the same once he got the iridoplasty for at least 5 years. Macula OCT is normal. I do an OCT on all my patients before cataract surgery, premium lens or not. And here is his biometry. So we went with a 22.5 for the right eye and 23 in the left eye. I just saw him. He's actually more than 22 years out now, and he's one of the patients that got great uncorrected near vision too. I never promised this, but as you can see, he's 20/20 for distance, intermediate, and near. Next is a dry eye patient that I will show you for the interest of time. This is the dry eye cohort from the study. It basically showed the same things: excellent distance vision, spectacle indifference, good patient satisfaction, very limited visual disturbances. And I'll show you my patient. This is a 76-year-old woman that has legitimate dry eyes. She is diagnosed with Sjogren's syndrome. She's on Medrol and Plaquenil for years. She's using preservative-free artificial tears several times a day. She was never on topical cyclosporin, punctal plugs, or serum tears. So her dry eye is controlled. She doesn't have severe dry eye. She is a low myope because of her cataracts lately, and she doesn't wear glasses. She tolerates a 20/40 distance vision, and she has her minus 150 for near because of her cataracts. So here is her refraction, and I will show you her ocular surface. This is the picture on your left. This is her eye. As you can see, she does have some mild dry spots on the surface, and this is why I thought this is a patient that could benefit from this lens. Just a word of caution: if you see severe dry eye, like the photo that you see on the right, please don't think about implanting a premium lens, because these patients have a lot of aberrations from the dryness. But she was mild, well controlled, and I did mini monovision for her. So the right eye was plano and the left eye minus 0.63, because she was used to be able to read, and I wanted to make sure that she was going to be satisfied. And she got binocularly great distance and intermediate, and she's 20/30 for near. So in summary, the VIVITY registry study showed us that most patients in that study, of the 910 of the overall cohort, achieved 20/20 vision for distance, except from the sub-cohorts, the ones after corneal refractive surgery achieved about 20/25. And all of the patients had a high degree of spectacle independence, high rates of patient satisfaction, and no visual disturbances in about 88% of the patients. And with that, I would like to thank you for your attention and my family for allowing me to be here today. Thank you.